Thanks for coming, especially with the osteoporosis treatment we had last night until 4 o'clock in the morning. We're going to talk about shockwaves in sports. Shockwaves in sports are our brothers. It's the main issue that we do in shockwave medicine. Out of all the centers that work with shockwave medicine in the world, 85% of the treatments are related to some kind of tendinopathy or sports-related effect or issue. So we have nothing to disclose or no conflicts of interest. I come from Bogota. This is Universidad del Bosque. And this is the place where we have our Shockwave Excellence unit. It's not the whole building, it's just this thing here. So basically in sports, we know that healing difficulties or problems represent the greatest issue in the recovery of musculoskeletal injuries. If you could have a hypothetic curve or complete healing ability with the injured tissue, we have to deal with really complicated things. You know, the muscle recovers functionally almost 100%, and the cartilage, you're born with a certain amount of cartilage, and then you never get it back again. So in the middle, you have tendon and ligament that more or less heal well. Bone heals very well. Nerve never heals in certain cases, and cartilage never heals at all. It's just replaced by some other tissue. You know that acute sports injuries are usually well treated when they're acute, and they're well-known protocols with the intervention of everyone, with the help of the other teams, and with the intervention of some very good and with good initiative colleagues from physical therapy, for example. But you know that sports injuries frequently result in healing diseases. Problems like in muscle with tissue defects, and tendon and ligament with tendinopathies and tendinosis, palsies, cartilage with chondromalacia, arthritis, and bone with stress fractures or vascular necrosis. So once they become somehow chronic, it's a real problem for us in orthopedics. And we have to deal not only with difficult tissues to heal, but also with mechanical forces all the time. And mechanotransduction is crucial in the healing of all these tissues, from bone to tendon, from muscle to cartilage, from meniscus to a ligament and the joints. These are really challenging situations for healing. So for shockwaves in sports, we have in tendinopathies, which is the basic things that we treat, fasciitis and bursitis, stress fractures and pubalgia. Those are some of the things that you will see today and you have seen already in lower and upper limb tendinopathies. We have to be based upon the general consensus and parameters of our society, the regional societies, the national societies like the Colombian Society. And this is what we have. In chronic tendinopathies, approved indications are plantar fasciitis, Achilles tendon, epicondylopathies, lateral, rotator cuff with or without calcification, patella tendon, and greater trochanteric pain syndrome. Then you have all the bone, and basically with sports, we deal with stress fractures here. And also the other tendinopathies that we use a lot are these: ulnar epicondylopathy, adductor syndrome, pes anserinus, peroneal tendon syndrome, and all of them are usually related to sports activity or some kind of loading. All the rest are basically the empirical. So as you see, most of our problems have to deal with tendon. Tendon and the tendinosis or chronic tendinopathy is not an inflammatory disease. It's not an inflammatory condition. It's a vascular and cellular change that result in the loss of biomechanical and all the elastic properties of the tissue. And that's what basically happens. Once you understand that tennis elbow is not a painful condition, it is really like the heart attack of your elbow, then you understand why the shockwaves are good for us. We could define the insertional tendinopathy as the abnormal load transfer bone to bone insertions when the elastic properties of tendons are lost because of the tissue degeneration. And if this has to do with a very high loading tendon, like in sports or high competition athletes, it's a very difficult issue to handle. You know, the treatment for us is to work on this little cell. We have to normalize vascularization. We have to stimulate this little tenocyte to differentiate. and we need him to produce collagen around, so it produces matrix. But the player and the coaches and the patient doesn't care about that. They want good pain control, they want recovery of mobility, flexibility, and power, and they want to return to sports and work as soon as possible. So the treatment in general is pain control, pain and inflammation control, the promotion of healing, muscle balance, the control of abnormal external forces. And there are different strategies trying to get this, from medication to physical therapy. Unfortunately, we don't have more, our patients are high competitions, but we also have the weekend warriors that load abnormally the junctions of the tendon and the muscle and bone. We know from the literature and our experience in medicine that almost 80%, 8 out of 10 insertional tendinopathies heal with physical therapy, rest, and medication. We know that very well, but we know also that the other 2 develop a tendinopathy, a chronic tendinopathy or a tendinosis. And these are the guys that go from here to there, and they have pain again and again, and they go from physical therapy to a doctor and then to another one, and they end up with 5 or 6 injections of steroids in the tendon and breaking them. We know that pain control is much better in a tendinopathy to have a good physical therapy than a good pill, because it's not an inflammatory thing anymore. It has to do more with loads and motion. We know that the NSAIDs are very useful in tendinitis, in the acute phase, but they're good for pain control when you're doing physical therapy, but this is not the treatment. And steroid injections, we have to be very careful with that because they're very powerful analgesics, but in many studies, they're very similar to a placebo after 6 months. They're not as good. They decrease collagen production, the matrix gets crystallized, and there's always the risk of partial or complete tears. Actually, if you go to the literature, you will find more reports of tears of ligaments and tendons with injections than with any other intervention, including shockwaves. And this is what may happen. If you inject a tendon, then you will have crystals if you do it many, many times. You know, this is collagen, type 1 collagen, and type 1 collagen likes to be calcified. And as soon as it's ischemic, it will create a very good environment for crystals, for example. Rehab is a clue. This is the treatment for tendinopathies. This is the treatment. We are part of the rehabilitation treatment. It's based on temporary leave of sports, rest in inflammatory phase, low resistance in concentric exercises, progressive increase in repetitions and resistance, and then work in muscle power and balance, flexibility, specific muscle strength, sports gesture, which is absolutely crucial, and then prevention of all the abnormal external loads. We like to operate. That's our major thing as surgeons. And what are the goals of surgery in tendinopathies? We remove the pathologic tissue, we promote bleeding in defined areas, we stimulate the neurovascularization, and we create areas of controlled healing. But many things, good and bad, can happen to you, and the whole process from just the emotional side to the physical side is horrible. If you compare it with shockwaves, we can do exactly the same things, except for removing pathologic tissue. We increase vascularity, and then we can remove some of the tissue, but actually the rest of the things we can do exactly the same in tendinopathies with shockwaves as compared with surgery. Everybody knows this nice series of slides from Dr. Rompe in Mainz, published back in 1998, where you see the normal tendon with vascularity, this around the tendon, a very low cellularity. And when you apply shockwaves, low energy, you just get the stimulation and all the cells get like awake. And then after 7 days, you have some migration and differentiation of this fibroblast. But if you apply a higher dose of energy, then you really have an inflammatory kind of histology here. And the nicest thing is that after a couple of days, you get this, new capillaries. And we didn't really know much about this until 2006 when we got visits from Murad and all the people that were working in neovascularization and showing us that we were producing actually new blood vessels, and we didn't even know about that. Dr. Wang showed us for many years all the common gene expressions in shockwave application over the tissues, and all of these actually, especially these ones here, are the ones that are creating a new environment for healing in tendon and ligament. And then if you see his own studies from Dr. Wang, It has also the new vascularization in the junction of the tendon and bone area, which is exactly what we want. We want to have new blood vessels in those areas. Due to this tiny little cells that are so beautiful and so thankful for shockwave medicine, the parasites that create the new capillaries like this that you see here. So we're bringing new blood to these areas, and we're changing destructive technology into a tissue regeneration technology, which is the thing that we do. There is not one single shockwave meeting that somebody shows this Wang's slide, because it's very important to change physical energy through the biological response into a tissue regeneration, specifically in tendon and bone, by improving blood supply and neovascularization. So that's exactly what we do. In our tendinopathies, in Fenway Medical in Bogota, most of our problems in sports are related to elbows. Then we have plantar and patellar and Achilles, but basically we do a lot of shoulders. So I'm going to show you in shoulders what we do, in elbows what we do. Remember, probably the most important thing to the people that are new in shockwave medicine is the differentiation between the focused or defocused, the radial and the non-radial, the pressure and the piezoelectric and the electrohydraulic. The consensus statement of our society shows that for focus or defocalized or defocused extracorporeal shockwaves, you can do basically by physicians, and here what we do with the radials can be done by physicians or physical therapists. We can use them both in sports. Actually, the difference between the focal and the radial is the place that you put the energy. Here, the energy goes this way to a distant point, and here, the energy goes here to a very close point. So the point of maximum energy is here, the point of maximum energy is here. So both of them you can use in sports. Actually, well, this is a lot cheaper to use, this is a little bit more expensive, and probably with this one you will get better results. But the difference between one or the other in cost benefit in all the series in the literature favors the radials for sports medicine. The protocols are a bit different. When you use the electrohydraulic type of machines, the focus devices, we use only one session, usually one session per 2,000 shock waves, and that's good because time is also money, and if you have a device that does only one session, it's pretty good. We use progressive energy. We usually never go beyond 0.12 millijoules per square millimeter. The maximum pain point and also the tendon insertion is attacked. The good thing about these devices is that you can go almost with no problem over the bone because it's a membrane. If you do that with a radial, then you will have a lot of pain. But anyways, that's not the place that you want to do the treatment. You want to do the treatment in the place where the bone and the tendon join. We use no local anesthesia ever, and we do the pre and post-treatment assessment with pain scores, function scores. We record all side effects and the return to sports. The main difference with when we use the radials, they can be used also by our physical therapists and our sessions. We do at least 2,000 shock waves per session, 2 sessions with at least 2,000 treatment shock waves. A treatment shock wave in tendinopathies in this kind of devices can be defined of an energy above or beyond 2 bar. If you are under 2 bar, then you will have no effect on cells, probably only in pain. So it's progressive. We go the energy from 0.01 to 0.05 millijoules per square millimeter, depending on the energy that is provided by the manufacturer. We use it in the tendon insertion, as you see here, for example. You know, the window for treatment, for example, in this medial epicondyle, here's the ulnar nerve, here's the epicondyle, and here's the muscle. So the treatment window is really, really narrow. It's just this area. If you go this way, it will be very painful. If you go down here, it will cause reaction on the bone and a lot of pain. And if you go a little bit down, then you will create reflex, and the whole elbow and the hand will move a lot. So the treatment that we do is progressive, as you see. We start with a very high number of pulses and very low energy. And usually when we were around 2,000, we were in around 10 hertz and 2 bar. And here we start the treatment. It says treatment starts. And then we go all the way until we finish those 2,000 shocks. If you see this in a curve, we start like this, very high number of repetitions with very low energy. When we are around 2,000 shock waves, we're usually around 10 in hertz and usually around 2 in bar. And then we try to go as high as possible. And then you stop. And after you stop, you do another protocol of analgesia. So that's why we do all these 6,000 shocks every time a patient comes for those 2 sessions. We made the recording, a record of everything, and we do a graph, and we also do a little analysis of how the patient has improved or decreased his pain, or if he has any other side effects. Specifically in tennis elbow, which is, as I tell you, like the heart attack of the elbow. That's usually for this ECRB muscles, extensor carpi radialis. This is what we have. Usually when we treat the patients initially, we always use the radials at the beginning. If we have to go for a 3rd session, which is only in 18% of our patients, we go for a higher energy in our center. If you only have a radial, then you will have to repeat for a 3rd time and no more than 3. Patients usually have the same, and this is like the example of every tendinopathy in sports medicine. You have a very high, usually they come between 7 and 9, they go down after the 1st session, then you go up again for the 2nd session, and then you go down, and this keeps going on like this for years, actually. In return to sports, you have a very good and nice return to sports when you're using shock waves, and then the fair and bad results go down. The same thing with the functional scores after a year. This is pretty much with every tendinopathy. It just goes up in good and down in bad. Here's one of the studies that we presented in Milano, and here you see how excellent results are going up, and this is a follow-up for 24 months. And this is pretty much the same thing in every insertional tendinopathy. I think that only shoulders do behave differently because it is not an insertional tendinopathy, but also a lot of variables like compression with the acromion have a role to play. And the other one is Her Majesty, the knee. So the patellar tendinopathy is the largest tendon with very poor vascularization and a lot of loads. So there we also have some trouble. In plantar fasciitis, which is right here in the chronic insertional tendinopathy of the fascia, plantar fascia, we got our training from the Weil family in Chicago. We can do them both also with big devices, with small devices, and basically the area where we have the treatments, or when we do the treatments, is this area here. It's a little bit medial in the very insertion of the plantar fascia. We do exactly the same protocol, and our results, as you see, are pretty much the same. It's go down, and then up a little bit, down, up a little bit, and again. Nobody comes to the 2nd session with 100% of satisfaction, ever. Just be used to that. That's part of shockwave medicine. As doctors, we have to expect and tell the people, you will come with some pain, you will have some days that are good, you will have some days that are bad. But it doesn't behave like a surgery that is a curve that goes like this. Shockwaves go like this, and then you have less pain and longer periods of time, but it's usually coming like this. So don't be discouraged by this. In Achilles tendinopathy, unless you have a high calcification, we always use also radials. In this cases and in patellar tendinopathy, we also use MRIs or ultrasound if you have a skilled ultrasound doctor that helps you. And for pain, and specifically here, we're doing a study also with laser for pain. So we use high intensity laser before, and that way we can improve also our treatments. As you see, many devices have been used in history, like these huge devices for Achilles tendinopathy. We have almost the same results. The higher the energy, the better, but in this tendinopathies, it is pretty much the same. As you see, the curve is almost the same, almost identical. It goes down, up, down, and it keeps going for months and years. Shoulders are terrible because shoulders have all this impingement or it may have a partial rupture. Actually, in our center, it's more, we reject more patients of shoulders than anything else. And then many of them have to have surgery and they don't want to have surgery. So they enter a protocol that is more for pain and rehab than a protocol for tendinopathy. So that is very important. And it may happen that you may have in shoulders a big calcification or not. If we have a calcification, and it's a calcified tendinopathy. We prefer to use high energy. If not, if it's just a tendinopathy, we go for the smaller devices and the radials. This is from Dr. Giloff, has shown us the good position for to attack this area here, which is basically you do a little bit of extension and internal rotation to expose this area, and this is where we have to attack. And the truth is that the patients that do have a calcification and lose their calcification get better. Those are the best results. But anyway, you only about 50 to 56% in our cases, the calcification absorbs. So this is not the objective of the treatment, but it is a way to know that the patient really had. But don't expect this to break as a cálculo renal, like a kidney stones. You have to tell the patient that this will go out in between 6 months and a year, and then you'll be safer, because you have to wait until the vascularity you're creating with shockwaves just blows this thing out. So it's not like an explosion of a kidney stone. It's more like a vascular thing. Again, the curves are like the camel, up, down, up, down, up, down, and then it sustains for many, many years. That's a good thing. In tendinopathies, usually the area is here because you have poor vascularity here. You have very good muscle and blood vessels over here. You have the tibial insertion of the patellar tendon, which is also very well vascularized, but this area here has to move back and forth, and after 30 degrees, it's absolutely avascular. So it causes a lot of problems. So you see the curve is a little different. They don't behave as well. So you have to have as many strategies as possible to treat these patients. We use high energy, we use stem cells, we use everything that we can. Usually we start with radials, go again in the second session with the big ones, or if it's a high athlete, high energy, high demanding athlete, we go straight for the high energy ones. There are tons of literature about patellar tendinopathy, and all of these are with focus, and all of these are with radials. So you have, both of the energies are pretty good, but one thing you have to remember is that patellar tendinopathy is the one tendinopathy that gets more surgeries. That is the tendinopathy that is usually operated on when it doesn't work. If you have your elbow, well, you can live without your elbow and you stop playing sports, and many people will say, surgery? No, thank you. But then in patellar tendinopathy, you have to have surgery sometimes. So the differences are this: all the behaviors in sports are pretty much the same, except for patellar tendinopathy, which is more like a camelback over here. But they all behave pretty well. Here you see another curve. And passing from tendon to bone, there are some applications in sports. Ankle injuries are also related to some osteonecrosis, post-traumatic osteonecrosis of the talus. We already did this study, and it's one of the things that we've done. We apply the shockwaves on the area where the talus has the osteonecrosis, and this is pretty common in sports. Before shockwaves and after 6 months after shockwaves, then you have the bone scan showing a real nice improvement, and the MRI is pretty dramatic, but you see before and after 6 months and no pain whatsoever. And this guy used to be a resident and now is an orthopedic surgeon. He plays active football. You can stimulate the subchondral bone actually by doing the stimulation that we do usually in surgery, but outside, extracorporeal, and Richard Thiele has beautiful work on this. Another one in sports is tibial stress fractures. Long time ago, 2004, 2005, we did this study in cadets from our Navy school, and it was a very nice study for 16 Navy cadets, 18 years old, bilateral, identical tibial stress fracture, and we just applied on one side and a placebo on the other side to see what happened. And what we found was that after doing these treatments, we evaluated pain in rest and sports. Here in blue are the treated, in red is the controls, and you see that after probably 6 months, everything is the same. In sports, after a year, everything is the same if you just do the rehab protocol and not shockwaves. But if you do shockwaves, you have very nice, statistically significant differences in the beginning. At 6 weeks, and especially around here, in 9 weeks, 7 weeks, you have a lot of difference in rest, and after sport pain, and in pressure pain. All of these were validated, and they're being used actually in a couple of Navy and Army centers in Israel and in Mexico and in Colombia. So we found that it really reduced recovery time, sports and training activity was better, bone scans did not change after 1 year, but you did get a better time of recovery, and that's crucial for military. They don't have to go, and also in sports, because usually you have to leave a sport. Cristina D'Agostino loves this picture, I don't know why, but this is the other situation, pubalgia. Pubalgia, the high symphysis pubis is basically because of the muscles of the abdomen, and it's usually hernias. And then the lower pubalgia, it's around the inguinal ring and the adductors, but most of them are a mixture of both. And in that area, we have presented 51 cases from 2004 to 2013. We follow them for 2 years, those 34 cases, with VAS and satisfaction scale, and if they fail, they will go to surgery with their sports teams. This is what we do. Basically, we use 2 sessions in 2 weeks with a focalized system, 2,000 impulses per session at 0.12, no anesthesia, and this is the way that you apply the device, and you just work on this direction. This is also from Ana Claudia, the #1 expert in pubalgia in this continent. The physical therapy after treatment is usually 4 weeks, and we follow also the patients and the sports athletes with this. Here you have physical therapy, and here you have physical therapy plus shockwaves. And again, you have a better result earlier. If you do a good program of physical therapy, you will have some good results, but it is much, much better if you have this, especially in terms of time for a football player. It is crucial. You see here is 32% of difference at 1 month and 22% of difference. The 2 very significant moments are 1 month and 3 months. So that's very important for a football player, for example. This is very common in football. Here is satisfaction of treatment, shockwaves versus physio. Here you have just the bads, and here are the fair, and these are the good results. So they usually have what we like to see. This is the good results going up and the bad ones going down, and no harm. We were very afraid of injuring or doing something with the bladder or with all the internal organs, and we didn't have any problems there. Not anymore, not with the devices we have. So in summary, orthopedic shockwave biosurgery or treatments in sports injuries pass from just technology to developing a very nice system with past, present, and future. Our job as a national, international, and regional societies is to make everything work under the conditions, because it is easier to understand what happens in bone, but in tendinopathies and in sports, it's only pain, and pain is an emotion, like love. So everybody loves differently, everybody feels pain differently. So it is very difficult to assess. Try always to follow the leaders, the society parameters, and that's why we are here, to make everybody work in the same way so we can get the same results. Ludger Gerdersmeyer gave me these 2 slides, and I was very surprised to see how shockwaves are so popular in the German and French and British teams, as well as also in professional sports in general. So I love to show this to the insurance companies and to the football teams, because it's very important. And when we showed this a couple of years ago to the best team in the world, which is this one that you're seeing here, even though it's ranked number 4 in the world out of 285 teams, the good thing is that all the success of these people is because they're great athletes, they have a great coach, but also because they have a great doctor, Dr. Ulloa, who must be around here somewhere, who's also certified and trained and gives shockwaves also to her boys. So, our conclusion, shockwaves in sports. We have a significant improvement of pain, significant improvement in function. We have earlier return to sports. We have no complications that are not even severe, very mild, and a very high satisfaction. So this is what we call a winning treatment. That is what you have to think and take home.